Welcome to the Ty Beal Show, where we discuss food, science, and life. I'm Ty Beal, a scientist at the Global Alliance for Improved Nutrition, or GAIN. My guest today is Dr. Gil Carvalho, a research scientist, science communicator, speaker, and writer. Dr. Carvalho also hosts Nutrition Made Simple, which aims to convey fundamental nutrition concepts to a general audience via educational videos, with over 1 million viewers monthly. In our conversation, we discuss plant-based diets, longevity, and cardiometabolic health. A quick note before we start. This podcast is separate from my role at GAIN. Okay, let's dive in. Dr. Gil Carvalho, welcome to the show.
Thanks for having me. My pleasure.
Yeah. Well, most people know you as the host of Nutrition Made Simple, or online, where you're pretty active. You publish educational videos translating nutrition concepts into simple explanations, and they're really great videos. But you're also an established research scientist. Many people might not know that. What led to your passion for science communication particularly?
Yeah, I was looking for a way to translate what we do in the lab. Sometimes it's years of work at the bench, and then you don't see a direct application to people's lives, depending on what you're doing. And we did a lot of work with model organisms. So sometimes it's a long road to human application. And I was looking for a way to apply everything that we know scientifically about food and health and heart disease and all these things that people often don't know. And I explored different things, podcast, book, this, that, the other, blog, and I landed on the YouTube because I like to talk to people face to face, and so the YouTube is a good fit.
Awesome. Well, I'm really glad you do it. They're really helpful videos, very balanced, and I had a similar sort of experience, wanting to be a professor and doing research, but then thinking, wow, there's such a disconnect from the research to the impact in nutrition, and so I was really drawn to doing direct programs, around the world. So that's kind of how I got into that. You're an advocate. Most people know that you're an advocate of plant-based diets. Curious to know if you've always been interested in plant-based diets, or did something lead you to that sort of focus?
I guess it depends how you define plant-based. Because in research, when you say plant-based in nutrition science, it encompasses most diets. Really, it encompasses Mediterranean, pescatarian, prudent omnivore, even. Like, it encompasses a lot of different things. It just means that the diet has a lot of plants, a lot of fruits and vegetables. Online and on social media, if you say plant-based, most people will think of vegan diets. And I don't see a convincing scientific argument that vegan diets are necessarily any better than a variety of other food compositions. I'd say that's kind of a summary of the evidence that I've seen over the years is, we have overwhelming evidence that a diet with an abundance of unprocessed plants is health promoting for the majority of people. But when people insist, no, it has to be vegan, or it has to be vegetarian, or it has to be pescatarian, I just haven't seen compelling evidence of any of that. It seems to me that all of these diets are roughly equivalent, including Mediterranean, kind of on par with all of those, and it's very hard to find, mainly because it's difficult. Like, it's really difficult to design experiments that are going to separate diets that are 90% similar, especially when your comparison, right? Your comparator, the standard in the West, is so miserable that all of these diets are going to be so different from that. And then to find separation in the 5% of their differences is going to be tough.
Yeah. So
I just haven't seen convincing evidence that it makes a big difference whether it's 100% plants or 90% or whatever.
Yeah. Yeah. So the very, very different understandings of what plant-based means, anywhere from 100% plant-based or vegan to vegetarian, which includes oftentimes eggs and dairy products, flexitarian or sort of pescatarian, which includes some fish, and then even omnivore type diets that are including a lot of plant-rich foods. So what you're saying is there is a lot of evidence to suggest that consuming a lot of plants in the diet, minimally processed plants, fresh fruits and vegetables, those types of things, are really beneficial overall. And the distinction between what exact percentage of the diet is made up of plants versus animal products is not really as well settled, right? Like this discussion around how much animal source food should you have in the diet. So we can talk about this a little bit more. I want to know your view, because you've talked a bit about longevity and done a bit of research on this area. So what, in your view, what is the evidence regarding plant-based diets and longevity? How do they relate? How does this sort of what you eat impact how long you can live and sort of a healthy lifespan?
Yeah, so there's a couple of lines of evidence. So there's observational, then there's randomized trials, which have some strengths, but they also have the limitation of scale and kind of the time scale that you can, how long you can go. And then there's some genetic data. In general, they all agree on the big points. And so there's a big study that just came out of the Harvard School of Public Health, where they tried to look at healthy aging. So this was absence of major disease, into your 70s or that range. And yeah, they find that essentially the diets that we were talking about just now, diets with an abundance of plants, but also things like fermented dairy, fish, basically the definition of a traditional Mediterranean diet, right? These things are consistently linked to this healthy longevity, and then things that differ from that. So it might be a lot of ultra processed foods, a lot of junk foods, large amounts of processed red meats, for example, consistently linked with disease and the opposite of healthy aging. They showed this large data set. Then to put this in specific numbers, it was about 10 to 12 years gained if everything was optimized compared to like a standard Western diet.
Wow.
So this is obviously average of everyone. And then you have genetic data. We can get into more detail if you want, but just to kind of give a first pass to not go too into the weeds. The genetic data looks at kind of unbiased, looking at what mutations, what genetic variants are linked with longevity, with dying later. And you generally see these causal risk factors, the lipoproteins like the ApoBs and the glucose levels and things like that, alcohol intake to some extent, all these things that classically have been established as major risk factors for disease, they come out in the genetics as well, which is a more modern line of evidence that kind of confirms previous lines of evidence. So that's always cool to see. And the link there is that to optimize these risk factors, typically in most people, what you have to do is precisely tweak the diets in that direction of a, Mediterranean-ish diet. That tends to optimize the body weight and the glucose metabolism and the lipoproteins all at the same time. Again, we can talk about individual variation, but in general, that's where you see kind of these risk factors all drift towards the normal range. And the more we, differ from that in terms of dietary pattern, the more we see risk factors kind of go haywire.
Okay. So in general, a lot of genetic variation, but for most people, this is going to be a positive impact on their overall longevity and health span. I do want to get into a little bit more of the weeds about the variation because, this is sort of from people's perspective, but you hear those who feel like they thrive on a plant-based diet and those who feel like, that doesn't really work for me very well. I'm more of sort of a lower carb with more animal products. And there is some data to suggest when in any population, in any study, when you compare two groups, you always have a distribution. And there are always people who do better or worse, even when you look at their biomarkers, right? Can you tell us a little bit about why that is and why maybe plant-based diets in the sort of strict sense are not necessarily ideal for everyone?
Yeah, so I think there's two things to maybe tease out here. One is individual variation. Another is short-term versus long-term, because a lot of times that gets conflated.
Yeah.
A lot of times I'll talk about long-term effects of things, and someone will say, "Well, this science must be wrong because I'm eating a diet that is the opposite of this, and I lost weight and I feel better." I believe you, but there's no contradiction there. You can lose weight and even feel much better, and your risk of chronic disease could have gone up. I'm not saying it has for you individually, but just understanding that there's no contradiction. The short term and the long term are not necessarily one and the same.
What about,
So that's
yeah,
just one.
while we're
Yeah.
talking about that, what about this? What about the idea that potentially a different type of diet for a particular purpose? So let's just say it's for weight loss, or if it's for treating some sort of condition that is disrupting how you feel, right?
Yeah.
What about the idea that, in this stage of life or this period, maybe one type of diet may be necessary, but then that doesn't mean that the diet for the rest of your life should necessarily be the same. There's also that potential, right?
Absolutely. I mean,
Yeah.
some of these are clinical practice, like routine practice. So, for example, you have certain intolerances to a number of foods that contain fiber. So, if you have gastrointestinal conditions, IBS, things of that nature, uh, you a clinical approach is a low FODMAP diet, right? Which
Yeah.
removes
Yeah.
a number of fiber sources from your diet. If you have celiac disease, you remove gluten containing foods, right? Wheat,
I
barley,
like
and
that.
rye.
Wheaten. We should
Wheaten,
call
yeah,
it
yeah,
wheaten.
yeah. Start the new fad, the wheaten diet.
Yeah, the wheaten diet.
Yeah, so wheat, barley, and rye, the three gluten-containing grains, you
Yeah.
have to remove those, and yet those are health promoting for most people based on the data we have. I
Right.
mean, there's endless examples of this: peanut allergy, on and on, lactose intolerance, all these individual needs that don't mean that the same food is bad for everyone else.
Mhm.
So undoubtedly, there's a ton of room for personalization. I think this also a lot of times this gets confused and this gets exploited on social media, where someone that has one of these intolerances will try to make the point that food must be poison for humanity because they experienced an improvement when they removed it from their diet. We have to make that distinction that I
Mhm.
may have an intolerance to something. That doesn't mean that you have to remove it from your diet. If I'm lactose intolerant, that doesn't mean milk is poison for you,
Yeah.
right? We'd have to, but this is all nuanced stuff that I understand is harder to get across, and it's much easier to say this food be poison. It's a much more memorable message and more inflammatory and more pun intended and
Yeah.
more visceral than explaining it.
Right. Okay. Well, that makes a lot of sense. I fully agree with you. There's also another issue that people bring up oftentimes when we're talking about plant-based diets, and that's, can you get enough protein and micronutrients, vitamins, minerals, things like B12, calcium, iron, zinc. What about the omega-3 fats? What do you say to people who sort of raise that concern?
I think it depends on the composition of your diet. You can certainly mess it up. You can certainly, and some people do. I think these are more of a concern with entirely plant exclusive diets, with vegan diets. So yeah, if you're on a vegan diet, you have to have a source of B12. You'll find mythology on the internet that you don't need it. It's all a hoax to sell B12
Mhm.
pills and our ancestors, yada, yada, yada. None of that is backed by science. You need a source of B12. It's
Yeah.
incredibly dangerous to eat a diet without a source of B12. You're not going to feel it right away. Again, short term versus long term, you can be without B12 and your reserves will supply your needs for a couple of years and
Yeah.
you won't feel anything. And you might feel better because you just removed a bunch of junk food. But long term, you can have enormous issues, nervous system, all over the place.
Yeah.
So you need a source of B12. It can be supplements, it can be fortified foods, it can be animal products. That's personal preference. They all work well. They all been shown to work really well as reliable sources.
Hmm.
And then some of the other things are similar, like calcium, for example. Again, depends if you're a vegetarian or a vegan or Mediterranean, completely different considerations there. If
Yeah.
you're on a vegan diet, I think it is something that you should plan for. There are good sources of calcium from plants. There are vegetables that are, for example, low oxalate vegetables, like collard greens, for example, very high in calcium and very good absorbability, very low
Hmm.
in oxalates. But so you need to be aware of these things. If you eat a a random diet or a junk food vegan diet or there's many ways to mess it up, and you can easily not get enough of one of these things if you're not planning correctly.
Yeah.
Um,
Okay. So
yeah,
low oxalate, which just for those who don't know, it sort of it prevents absorption of calcium, right? But
yeah.
some of these greens like kale, you mentioned, there's a few others, but
Kale is also
they can
good.
be
Yeah,
very high, right? And what I've looked at, because I was interested in this, is that the bioavailability is surprisingly good from these low oxalate greens. And
right.
in fact, by most studies, the bioavailability is pretty comparable to dairy, even. So some
Yep.
people may be surprised by that, but I did a deep dive into that topic a while back.
And then you have things like more processed foods that are more controversial, but I think a lot of people who are plant-based are eating some forms of, for example, if you have plant milks, some are supplemented with like vitamin D, for example. Some
Mhm.
have some calcium added. So those are all things that are going to add to your intake. So it just needs to be planned correctly. But I mean, I would say that about any diet. If you're on an omnivore diet, if you're on a low carb diet, all of these diets need to be planned correctly. For all of them, there are pitfalls and lots of things that you can mess up and have health issues as a consequence. So
Right.
yeah,
Yeah, makes sense. I mean, you can cover your micronutrient needs and have suboptimal lipid biomarkers, right? I mean, there's all sorts of ways for diets to go wrong. And in terms of other nutrients, I think for fully plant-based vegans, there are DHA and EPA supplements from algae, right? So there are
yeah,
options to get these nutrients, and even certain mushrooms, I think when they have sunlight, they can also have vitamin D in a format that's pretty available, and of course, getting sunlight. So there are options. I agree with you. I do notice because I do a lot of research in this area. When you go lower and lower, as you said, when you go if you go fully plant based or vegan, you do run into some trouble with these nutrients, and so you have to pay attention. But as you said, any diet has its issues, and when you optimize for one thing, you're not necessarily optimizing for something else. Could we just talk before we move on? Can we talk a little bit about protein, because I think that is one of the nutrients that people care about a
yeah,
lot, right? What is your
yeah.
take on that? How much protein do we need? What about this issue of plant versus animal protein?
Yeah.
What's happening there?
So I think the first level approach, I don't think protein is a nutrient of concern in general for most Westerners. I think the vast majority of Westerners are getting plenty of protein. So it's not something that we should be walking around pulling our hair over. I'm not getting enough protein for the vast majority of people. Now, when you get to more kind of fad diets like raw vegan and fruitarian, might it become a concern there? Yes, I'm completely open to that. Also, when you like people with specific needs, so older population, I think it starts to be more of a concern. Um, the older you are, if there's frailty, if there's problems with appetite, if there's problems with absorption, gut function, intestinal, absorption of nutrients, then yeah, I think that becomes more of a something to pay attention to.
Yeah.
Um, in terms of the need, I mean, I've talked to several of these protein experts on my channel. I've gone over a lot of these publications. I think there's a compelling argument that a little over the RDA is probably safer. So the RDA is zero point 0.8 grams per kilo body weight. And I
Hmm.
think that's probably enough for most people for maintenance. But yes, you might find some people that are on the edge with that amount.
Yeah.
So if you want to go a little higher, 1 or 1.2, I think that is safer, especially for an older population. The older you are, I think over 65 is a decent cutoff there to start paying a little bit more attention to the protein. And again, most people in the West are already there, are already at 1.2, give or take,
Right.
without thinking about it. Um, and then the plant versus animal thing. Yeah, I've looked into that. Most studies that have carefully matched for total protein content don't find much of a difference. And this is with pretty strict readouts like muscle hypertrophy, right? Which was arguably the highest threshold, the strictest um, outcome that you can look at.
Hmm.
And as long as you're getting enough protein, they don't seem to be a problem. And again, if you have a plant-based diet that is nothing but bananas and you're trying to lift weights and maximize hypertrophy, I wouldn't be surprised if you're not, reaching your goals. But if you have a well-planned plant-based diet or animal mixed diet or whatever, I haven't seen evidence that it matters much. If you're getting over, they have this reference value that they give, the 1.6 grams of protein per kilo body weight. It's a little bit contested, but it's in the ballpark. Maybe it's a little bit more, but in that range, that seems to be about where it plateaus. Kind of, you maximize hypertrophy. If you get more, you don't get more muscle above that.
Right.
And at that point, it doesn't seem to matter much if it's from plants or animals or mixed or protein powder or wherever the protein's coming from. Your body's going to break it down and use the amino acids. That's the other thing, is the amino acid breakdown. Sometimes there's this argument that it's incomplete protein. Yes, you can get enough protein from plants, but it's incomplete. Maybe if you're eating nothing but rice all day, then yeah. But if you eat a diversity of plants, and you can just throw this on Chronometer or something like that, and you'll see that if you have a mix of plant sources, some legumes and some soy foods and some grains and some vegetables, you'll see that you get a rough mix of amino acids. And once you get to 1.2, 1.6, it's really not much of an issue. And most people who are trying to maximize, as a last point, most people who are trying to maximize hypertrophy, kind of lifting in the gym and trying to get really buff, almost everyone's supplementing anyway. They're taking protein powders, they're taking creatine. So it doesn't seem to be a major concern even for bodybuilders.
Yeah, it could be plant-based protein or whey protein or whatever, and typically it's going to be okay. Yeah. Okay. Well, we can. I'll probably dive into this the protein topic a little bit more too on future episodes, but that's a good overview. Can we shift to cardiovascular disease? I think you sort of care a lot about this. Heart disease is a leading cause of death in the U.S. So just to get started, can you tell us what heart disease is and what causes it?
So there's a large number of different heart diseases. The number one in terms of frequency and how lethal it is atherosclerosis, atherosclerotic cardiovascular disease, ASCVD. And that's basically plaque buildup in the arteries, which is a chronic disease, progressive, not irreversible as we used to think. It's quite reversible and very preventable. And it's buildup of plaque in the artery wall where it's not, where these lipoproteins are not supposed to be lodged, but pathologically they do get lodged in there. And we understand a lot now about risk factors that precipitate this and ways to prevent it and even manage and even reverse it to an extent.
Okay, well, we'll get into it. Maybe you can tell us a little bit about what the key biomarkers are for cardiovascular disease. Like what type of lab tests should we be paying attention to or testing with our doctor? And along with that, do you have some guidance around the optimal ranges or suggested ranges?
Yeah. So starting with lipoproteins, which is kind of the epicenter of atherosclerosis. So for people who may be new to this, lipoproteins are nature's solution to transporting fats in the blood. Oil and water don't mix, so you got to transport fats back and forth as fuel, transport, fat-soluble vitamins. All these things need to be transported in your body to be delivered to different tissues. And so the way nature solved this is to create a packaging around the fats with protein and with parts of fats that get along well with water. And so these are these microscopic golf balls called lipoproteins. And so you've heard of LDL and HDL and things like that. That's related to lipoproteins. Those are actually the contents of the lipoproteins. But essentially, this is how the fats get transported. And the number one causal factor for heart disease is this thing called ApoB. ApoB is a label on these lipoproteins. So there are different families of lipoproteins in the blood. And one of these families is the ApoB family because it carries this tag of this protein on the surface called ApoB. And it's this family that causes heart disease. So the HDL type lipoproteins don't cause, they're not atherogenic, they don't cause problems. but the ApoB family does. And so it's the count of the number of these particles, the number of these lipoproteins. The higher the count, the higher the risk population-wise. So that's one big risk factor. Just to explain a little bit, when you get a basic lipid panel at your doctor, you don't get a count of lipoproteins. For historical reasons, you get cholesterol measures. You get LDL cholesterol, HDL cholesterol, triglycerides. These are all the fats, the types of fats that are being transported in there. And so this gets a little confusing because this is what people will talk about. And even at the level of doctors, this is mostly what doctors will talk about. But it's basically a reflection of the number of lipoproteins. And it's really the number of lipoproteins that drives the disease risk.
So it's almost like like LDL is almost like a proxy for ApoB.
Yeah. It's like it's like looking at the shadow of the person and trying to determine how tall the person is from the shadow, where there will be a correlation. If you measure the shadow of 1,000 people, it'll correlate with their height. But you can already see there's going to be lots of room for error depending on time of day and, where they're facing and stuff like that, where the light is. And so LDL in population studies will correlate with heart disease, but there's lots of contexts where it mismatches, where it gets it wrong, because there's what we call discordance, is when the LDL cholesterol doesn't match the ApoB. So these are kind of red flags, but just be aware that they don't always get it right, and there are more accurate measures.
Okay, so just to pause here, because before we keep going, I want to just clarify here. You're talking about, a standard lab would be your LDL cholesterol, which we, in popular culture, we typically think of as the quote bad cholesterol, right?
Right.
But what you're saying is ApoB is actually a much more specific marker of the atherogenic particles. And with that marker, can you tell us, for those who, you have to sort of ask your doctor for this, most doctors, right? But if you do get a lab back, there is a lot of talk, of course, for those of us in the field, there's a lot of talk about what's the optimal threshold, right? Can you you share your view on what you think sort of is optimal and why?
Based on the evidence we have, and there's new guidelines that came out, I think late last year. What they recommend in general for a young, healthy person is to try to stay under 90 milligrams per deciliter ApoB. And then as your risk goes up, there's stricter and stricter cutoffs. So, if you've had a heart attack before, obviously you have a very high risk. You already have a lot of plaque. You have the disease. So the cutoff is much lower. And then there's an intermediate cutoff. But let's say for a young, healthy person, you don't have a lot of plaque. You don't have like a crazy family history. You haven't had a heart attack. You don't have diabetes, any of these things that increase risk a lot. Under 90 is a good rule of thumb.
Okay. So now let's say you really want to optimize your cardiovascular health, or let's say you have other risk factors. What target do you recommend aiming for? Because I believe it lowers, right? As you sort of want to potentially, either you have other risk factors, genetic markers, family history, or you're really into optimizing your health because you want to live as long as you can. What would you suggest?
Yeah, it really depends on the individual's risk. So, like I said, for people who are who have very high risk, who are at secondary prevention, I think the cutoff is 60 for ApoB. So, secondary prevention means you've already had either a heart attack or a stroke, or maybe you've had a revascularization procedure. So, you have the disease at a pretty advanced stage. I believe it's under 60 milligrams per deciliter is what they recommend. So you want to be in your 50s or lower for ApoB. And then there's an intermediate cutoff that I believe is 70 milligrams per deciliter. So to try to stay under that, I actually try to, as an example, I try to shoot for this intermediate threshold because I have two genetic risk factors. So LPA, which you can talk more about, LPA is another risk factor for heart disease. And it's a type of lipoprotein as well. It's actually a type of ApoB lipoprotein that we've learned a lot about over the last few years. And about 1 in 3 to 1 in 5 people will have an elevated LPA. And it's a very nasty, very atherogenic lipoprotein. So it's genetically determined. That's the other thing. It runs in families. And there's relatively little you can do about it with lifestyle. Unlike your ApoB, you can modulate with lifestyle a lot for most people.
Mhm.
But LPA, there's little, you're limited in what you can do. And so that runs in my family. It's quite high. So because of that, I want to lower my overall risk more. And one way you do that is by slamming your ApoB. In my case, I try to keep it under 70,
Under 70.
as well as all the other risk factors. So glucose levels, blood pressure, body weight, all these things, and not smoking, obviously, um, um, body composition, like all these
Yeah.
things. I try to keep them really dialed in, because there's this one wild card that I can't fix yet.
So yes, I also have high LP little a, unfortunately.
Okay, sorry to hear.
That's unfortunate, but I agree with you, and
I hear it also causes extreme intelligence.
it's
I don't know.
intelligence and good looks, I think.
I haven't seen a randomized
That's what I've
trial,
heard.
Anecdotally, yeah.
Somebody told me that.
Right.
Exactly. Well, but for me, we can talk. We'll talk more about like different ways to lower that. I think a little bit further later. I'm curious to know for you. So you're saying under 70, optimizing all your other markers. There are some perspectives that lower is generally better. Some people maybe even trying to say go down to 40, 50. Do you have any concerns with going too low? Or do you think that there's sort of like a diminishing returns when you really start getting so low?
I don't think. Look, it depends what you mean by too low. An ApoB of 40, I haven't seen any reason to worry that it's too low, that it causes any problems. Now, I don't think it's necessary for a lot of people. If you have no other risk factors, if you have no plaque in your arteries by whether it's a CTA or an ultrasound or something like that, I don't think it's necessary. I wouldn't necessarily tell people to worry that much. But if someone wants to go that low, yeah, I haven't seen much downside. The usual concerns are, because I think this is the nuance here. Most people can't go that low naturally with lifestyle, so you're going to have to medicate, right? So there, yes, you have potential risk, potential side effects that are going to occur for some people. With any medication, that's always the case. A percentage of people are going to have side effects, and so I think it's always a risk-benefit determination. And so, if there's a significant benefit to be obtained, then it's worth going through that and optimizing and risking the side effects, and then navigating that for people who do experience the side effects, finding alternatives. But I don't know, for a 40-year-old that has no family history, no risk factors, maybe the blood work is good, lipids are awesome, but ApoB is not that low, and you even do imaging, and there's no plaque, and there's no calcium, and there's no, an IMT of the carotid is clean. I don't see the need to go that low, especially if the person maybe stays on top of imaging over the course of time.
So let's talk about imaging, because people
Yeah.
may not know what you're talking about here. We're talking about a couple things here, maybe a coronary artery calcium, so a CAC score, or even a CT angiogram. Can you tell us what these are, and when would you recommend somebody get one of these tests?
Yeah. So the calcium score, basically, it's a CT scan that detects the calcified portion of your arteries. So it's not going to show you soft plaque, but it's going to measure how much calcium you have in there. Essentially, calcium is bone tissue. It's not normal. You're not supposed to have calcium in your artery walls. But calcifications happen fairly late in the disease process. So with atherosclerosis, as the plaque builds, and often if there's rupture, then there's a scarring process that involves calcification. So that scan gives you a measure of the calcification. Now, there's a lot of confusion here, because it is a little confusing. In general, the higher your calcium score, the higher the risk of a heart, of an event like a heart attack. But it's not because the calcium itself causes a heart attack. It's because the calcium is a marker of disease that's extensive and that's been there for many years. So it's kind of the tip of the iceberg. And so sometimes calcium can go up, and it doesn't necessarily mean that risk goes up. So there's some areas of uncertainty there, and some misunderstandings, understandably. So that's the calcium score. Then you have the CTA, which is an angiogram. So normally you inject contrast, although not necessarily, and you can image the soft plaque, so the non-calcified plaque. So it is more sensitive. You can see kind of all types of plaque, and depending on the software that you use and the type of CTA, you can even discriminate the different types of soft plaque. So there's kind of things like necrotic core and a fibrotic plaque. There's all these different types of colorfully named plaque components. And this isn't just nerdy detail. This does matter for the stability of the plaque and how prone to rupture it is. So the CTA, I think, is safe to say is the more sensitive acid. Oh, there is a more sensitive option, but is more invasive, which is intravascular. You don't do that normally just for diagnosis. You do that if somebody of very high risk, or you're already doing a procedure and you get a little ultrasound device inside the artery, inside the coronaries, and then you image from inside the artery, and then you can get very good images. But you're not going to go through all that for a 40-year-old, healthy 40-year-old that's just trying to get a sense of the amount of plaque.
Okay, so we have CAC, so your coronary artery calcium score. That's for hard plaque calcification. It's sort of indicative that you've had some dysfunction for a period of time, right? A long period of time. We have the CTA, which is a bit more nuanced, looking at soft plaque. Can you tell us about when to get these tests? Is there, at what age? Is there certain risk factors? When should we be considering these?
Yeah. So I think maybe the more informative way to address it is, what do they tell you at different ages, right? So I've gotten a calcium score, for example, but my result was zero calcium. The problem is, at my age, having zero calcium is not that informative. So if it had been higher, it would be a red alert. But because it was zero, that's normal. Even in Westerners, which are pretty sick and die mostly of heart disease, number one cause of death, a calcium score of zero in your 30s or your 40s is the norm. So you get it at a relatively young age, more to rule it out. Okay. The older you are, the more informative a calcium score is. So if you're, or I would say the more informative a calcium score of zero is. If you're 70 or 80 and if you had high cholesterol or high ApoB your whole life and you have a calcium score of zero, that's good news. That means you probably don't have a lot of susceptibility, right? Mm-hmm. And vice versa, if you're young and have a high calcium score, that's also very, very meaningful, because it means you have very high susceptibility, very high risk of you lay down a lot of plaque, is what that's saying.
And you need to pay attention to it and treat it.
Yeah.
Right? Yeah.
And then a CTA is basically just a more sensitive. If your calcium score is zero, or even if it isn't, and you want to make sure, because sometimes your calcium, I guess this is important to explain as well. Your calcium score can be zero and you can have soft plaque. And you can even have a lot of soft plaque in some cases. It's not the majority of people, but it happens. And you can even have heart attacks with zero plaque. It's possible. So some people want to go the extra mile and get a CTA to make sure. There's room for debate here. Different doctors have different criteria for asking for these tests, and sometimes it's just, does the patient want it? Is the patient willing to pay for the cost? There isn't a super well established guideline for, if you're young and you have no risk factors, you can still get it. But it's going to be less pressing, let's say.
Yeah. I wanted to go back to this Lp(a), this genetic risk factor. I do think there is some progress being made on trials with drugs that are seemingly effective to some degree. I think up to, I don't know the number, is maybe 20-25% from some new drugs. So I think pay attention to what's coming out. Have you heard anything that's sort of in the works related to that?
No results, because they're not out yet. The results, the trials themselves are ongoing. There are drugs that have shown up to 90% reduction in LPA. So the potential there is insane, potential to be a real groundbreaking tool. What's missing is the demonstration that actually lowers events, so actual heart attacks and things like that. So we don't have that because these randomized trials are ongoing. I think the one that's farther along is Horizon, and I think the results are supposed to come out next year or 27 maybe. But then it'll be still a couple of years for authorization for FDA authorization to come out, and then it's probably going to be for people at very high risk, and it's going to be a while till these are even if they work. Yeah.
So is it possible? What you're saying is it's possible that the drug might actually lower Lp(a), but it might not actually reduce the risk in the same way, right?
Yeah,
we don't know
it's
yet.
Possible. It's possible. Yeah.
Now ApoB, if I understand correctly, is a bit different. When you lower ApoB, you are lowering your risk. Is that right?
If you don't mess up anything else, yes. If
there's no trade-off, that's too bad. Yeah. Okay. Well, let's talk about how to lower ApoB through diet and lifestyle, and then we can get into different medications.
So types of fats in the diet is probably the number one way. In general, foods that are higher in saturated fat, like butters and fatty meats, will tend to raise ApoB for most people, and vice versa. Unsaturated fats, things like olive oil, liquid oils, nuts and seeds, fatty fish, avocado, that will tend to lower ApoB. And we even know how that works mechanistically. The receptors on the surface of the liver that pull ApoB from the blood, those get modulated with the types of fats. So saturated fats, in general, it's not every type of saturated fatty acid, but the main ones in butter and fatty meats, they tend to reduce these receptors. So less ApoB is pulled from blood, ApoB stays longer in circulation, and vice versa. For unsaturated fats, more of these receptors, more ApoB removal from the blood. Then there's things like dietary cholesterol, which is not as powerful, and it varies more from person to person. For most people, dietary cholesterol has a modest effect. Then there are people who are hyperabsorbers of cholesterol who may see a larger effect, and there are some hypoabsorbers that see no effect. They can eat 20 eggs a day and it doesn't matter for their ApoB. So it's something that you can look at individually. There's some other components of nuts that also may have an accessory effect. So in general, the dietary patterns that they recommend is, again, Mediterranean-ish, with things like olive oil for fats, unprocessed fruits and vegetables, not a boatload of things like butter and other sources of concentrated saturated fat. This is kind of the summation of the literature for ApoB lowering.
What about fiber-rich foods like legumes, whole grains?
Yeah. Fiber is another factor, tends to lower ApoB as well, largely through reducing the absorption of cholesterol. So it tends to be a little bit of a lower impact than the type of fats, but absolutely, fiber is a factor as well. Yeah.
So I did an experiment on myself, and of course that's not it's not necessarily the type of science that we typically cite, but I want to share it because I think it illustrates something about individual variation. So I have, I told you I have this elevated Lp(a). I have a moderately high, not very high, but above the threshold for ApoB. So I eat a pretty minimally processed, nourishing omnivore diet, typically. So I had done that for a while. I got my cholesterol levels checked. I got my ApoB checked, triglycerides, all of that. And then I decided I'm going to do a strict change in my diet for a couple of months and see if I can make some progress on these, right? So I cut out eggs. I used to have, I would have 3 eggs every morning for breakfast with with a little bit of butter and a little bit of hard cheddar cheese. So I cut that out and I replaced it with just oatmeal with some fruit, basically, maybe just a little bit of honey. And I took the full fat Greek yogurt I was having, and I switched that out for fat-free yogurt. Okay, so no saturated fat. I took the fatty cuts of meat that I would have moderately, every periodically, and I replaced those with a lot of legumes, so lentil pasta, black beans, those types of things. Okay, I did this very very strict. Like I stuck to it for 2 months, and I got my test again. So my LDL went down about 8 points. My ApoB stayed exactly the same, which I was interested by, right? And then my triglycerides actually went up about 30 to 40%, or maybe 25% or so. So I'm just throwing that out there because for me, I really, I try to minimize how many medications I'll be needing to take. I'm not opposed to it, but I generally try diet and lifestyle. I tried the things that you're suggesting, and I did not see that change. So is that a potential genetic thing where maybe I am I don't sort of act like the average person in that dietary context?
It could be. I would ask about the baseline, the values, and the diet at baseline, because you're coming from a diet that's pretty clean to begin with, and I don't know what your values were. But it is saying that for you were already kind of optimized at the level of the lipids that, as far as your genetics will take you.
Yeah. So not as a lot of wiggle room.
Not from there on down, it seems.
So my LDL was 129.
Okay.
So that my ApoB was 103.
Okay.
And triglycerides were 79. So afterwards, after the 2 months, my LDL went from 129 to 121, but my ApoB stayed the same at 103. Triglycerides went from 79 to 101. And my LP little a was 126 nanomol per liter, nanomoles per liter. So
here's one thing that I would suggest is it sounds like most of your swaps were from cholesterol and saturated fat to more carbs. It was oatmeal, it was lean yogurt, and what was the other swap? Legumes and whole grains, right?
Yeah, legumes. So basically, legumes, whole grains, lean meats, and cutting out the eggs and low fat dairy.
I would try swapping with unsaturated fats a bit more.
Yeah.
So things like fatty fish or nuts and seeds, vegetable
I did
oils.
lots of fatty fish and nuts and seeds. And my oils, so my oils stayed the same pretty much. I mean, I did switch from, obviously cut out the butter, but oils generally were more of the monounsaturated, like the olive oil and the avocado oil. I'm wondering though, if I increased the polyunsaturated fats, oils, right? Like if that would have had more of a stronger impact.
Maybe. Yeah. The reason I say that is because we do, in general, in average, we see a stronger effect of unsaturated fats than carbs in lowering lipids and for cardiovascular risk as well. So they kind of match. But it varies. So some people go on low-fat diets, low-fat, high-carb diets, and their values slam. Like I've tried that in the past, and my values also go down on that. My values also go down on unsaturated fats. But yeah, there is some variability there, and not knowing exactly how much saturated fat. That's the other thing you can try to look at is kind of your ratio of saturated to unsaturated and how much that shifted, because it's mainly that ratio that determines your ApoB and cholesterol levels. So you can try to calculate what that ratio was before and after to see if there was a meaningful change there. But yeah, absolutely. For some people, depending on the genetics, they may not change much. And some people annoyingly are always low no matter what. Some people just eat whatever they want. They're always low.
It's not quite fair to the rest of us, right? Okay, so let's talk about what different drugs can be considered, because in my case, and probably in many people's cases, diet and lifestyle alone is not necessarily going to get them where they need to be. So that if that's the case, if you've tried that, or if you're sort of not having success, what would you suggest with the first sort of drugs to test out to try to lower ApoB and improve your lipids?
The first thing that virtually every cardiologist will try is a low-dose statin. That's what I tried as well. Like I've already tried 4 or 5 different classes of statins, and I did a lot of optimization. But that's usually the first line of attack. And then there's other things that you can add on top, like ezetimibe. Also, for people who have statin intolerance, these alternatives are sometimes used as a replacement. So there's ezetimibe, there's bempedoic acid. Those are the most common second lines when there's intolerance. But yeah, the first thing the cardiologists will try is either an atorvastatin or a rosuvastatin, 5 or 10 milligrams, the starting dose. There are supplements that can lower cholesterol and ApoB, and I think it's possible that they provide some benefit. It's just harder to get outcome data for those, and it's also harder because there's less control of the dosage, so it's more of a black box of what's in there. But yeah, there is some evidence for red rice. What is it?
Red yeast extract.
Red yeast rice. Yes.
Or red yeast rice. Yeah.
Yeah. And
red yeast extract.
Right.
There we go.
RYR. Yeah. It does lower cholesterol in randomized trials, but it's just hard to get the outcome data. Those are just really tough trials.
Yeah.
So it's more of a question mark as far as the end result. Other things, berberine can lower cholesterol in some people, but again, outcome is more up in the air. There are some things that have a smaller effect, like certain yogurts with phytostanols. There are things that affect also intestinal absorption of cholesterol. The effect tends to be pretty small. Yeah, the first thing that most doctors will talk about is a statin, and it's case by case. So I don't know if you've tried it. I had no side effects, but I have a lot of viewers who report having side effects. I have a lot of viewers who report no side effects. So it's
totally
very
hit and miss.
personalized.
You've got to try it out, probably with a preventative cardiologist, kind of testing these things out. I'm interested to know if there are side effects that you don't feel, but like impacts on blood sugar regulation, for example. Are there any concerns there, and how do you identify that, if there is?
Yeah. So there is an increase in both glucose levels and hemoglobin A1C that occurs in some people. There is also an increase in insulin resistance that occurs in some people. So I basically measured mine. That's what you want to do. You want to measure your glycemia and or your hemoglobin A1C and or get a measure of insulin resistance like a HOMA-IR. I did all of that. For some statin classes, I saw an increase. For some, I didn't. So it was specific to the statin and to the dose. It varies a lot also on the dose. And the other thing that we know now, because there's a lot of studies on this, is we see an increase in glycemia. We see this, what's called the new onset diabetes. It's people becoming diabetic on the statin. This happens overwhelmingly in people who already had risk factors. So they were already pre-diabetic or they had metabolic syndrome. Basically, they were on the road to diabetes, and the statin accelerated that, sped up that process. Okay. But people without those risk factors who are healthy to begin with, we generally don't see new onset diabetes just popping up. But insulin resistance can happen. So on atorvastatin, for example, I did see an increase in insulin resistance. And then on Rosuva, I saw no change at all. So it varies.
So did you end up finding a combination of drugs or a single drug that works for you to lower your ApoB, but doesn't have sort of any adverse effects to blood sugar regulation?
Yeah, Rosuva for me is the latest. It's what I've been on. Rosuva 5 or 10 milligrams lowered my ApoB to the range that I want, under 70, and no change in insulin resistance or glycemia, and no muscle pain. Muscle pain I actually didn't experience on any statin class. Okay. So that's been, for me, the best compromise.
Wow. Okay. So you have to try it out. you have to see what works for you because everyone sort of responds differently. You want to try to minimize any adverse effects while still getting the benefit from these, and make sure that it's not causing any side effects that are going to be long term really difficult, right? Because the goal is that to minimize your risk, you need to lower your ApoB over many, many years to really lower that risk. So what about blood pressure? We've talked a lot about lipids now. Blood pressure is huge, right?
Yeah.
The risk, high blood pressure is very common, and it's also a very high risk factor for heart disease. Can you tell us about why, like, how does blood pressure affect our arteries? How do we test? How should we measure that at home? How should we try to treat it? Diet, lifestyle, medicines. Whatnot.
Yeah. So it's a major risk factor, what we call a causal risk factor. Is not just a marker of something, but it's actually a cause, makes things worse, increases risk of heart disease. Absolutely crucial. And the good thing about blood pressure is, unlike these lipids, you don't need to go to a lab. You don't need to pay for anything. You just buy the device for $20 on Amazon one time, and you measure at home 5 times a day if you want, for free. No pain, no, not invasive. I mean, everybody should have a blood pressure device at home and know what your blood pressure is. We've learned a lot about this. The cutoffs used to be, when I was in medical school, what is it? I'm aging myself now, 20, 30 years ago. What is in the 90s. So the cutoffs were 140 over 90 was the cutoff for high blood pressure. If you were 135 systolic, nobody would bat an eye. Now it's not like that anymore. Over 120, we start to worry. And that's because we have more studies that have shown that pushing it to under 120 provides additional benefit. Mm-hmm. So now the new guidelines just came out for blood pressure, and normal blood pressure is under 120 systolic and under 80 diastolic.
Right.
And then over 120, it starts to be I think they call it pre-hypertension, but it's already
elevated or something like that.
Yeah, something like that. Depends also if it's UK or US. But it starts to be not normal, or it's certainly not optimal. And then over 130, it's worse, and over 140, it's even worse. Over 140 now is hypertension stage 2, which, in my lifetime, how much has changed.
Yeah.
So, and then control of blood pressure. A lot of parallels to lipoproteins, where we have a lot of tools just with lifestyle, both at level of diet. We know sodium and potassium are two molecules that are kind of opposing forces that control blood pressure. Sodium tends to increase it. Potassium tends to decrease it. Blood pressure, it does. And similar to lipoproteins, this varies from person to person. There's something called salt sensitivity. Some people can eat all the salt in the world. Their blood pressure is great. They can all drop dead. We hate them, but yeah, that's just the way it is. And so some people have high blood pressure no matter how careful they are. But the majority of people, it's somewhere in the middle, and your diet does matter. And then body weight is another thing that impacts blood pressure as well. So being overweight or obese tends to raise blood pressure. When you lose weight, blood pressure consistently comes down. Exercise helps lower blood pressure as well. So we have a lot of tools with lifestyle. One thing that I like to talk about, which is one of the best hacks we have that is actually science-based, are potassium salts. So you can swap even just some of your sodium salt, even just 25% of your regular salt, swap with a potassium salt. And randomized trials have shown a reduction in strokes and even mortality with just a partial swap. And you're still eating
some people, Some people really don't mind the flavor. I've tried the new salt. I've tried mixing it, and for me, the taste is just not the same, and it's a deterrent. But what I'll do is I'll add some every morning. I'll have like a teaspoon of psyllium husk powder, which also has been shown to reduce blood pressure, right? And I'll put in a little bit of potassium salt in there. Okay. So I just drink it down at the first thing in the morning. So there are ways to do that. And like you're saying, the potassium, from my understanding, is more protective when you have higher sodium, right? Because it's sort of this ratio of, if you're consuming a lot of sodium, you do want to make sure you're getting quite a bit of potassium, right, to be protective.
Yeah, it is. Yeah, it is a ratio. And the potassium, by the way, you don't need to get it from potassium salts. You can get it from your diet. In fact,
Fruits,
the DASH diet.
Legumes,
fruits, vegetables, whole grains.
Whole grains.
The DASH diet. That's one thing that one of the mechanisms through which the DASH diet lowers blood pressure and cardiovascular risk is a high potassium diet.
Yeah.
Yeah. So yeah, I would absolutely put blood pressure up there with lipoproteins, glucose levels, diabetes. Those things are all massive, massive things that you want to pay attention to.
Yeah. So body weight, you said, obviously the diet, sodium, things like that, but then also exercise, right? Can you tell us about how exercise affects that? Like, what are the key ways? Is it doing cardio? Is it doing strength training? Does it matter? How do we really optimize when thinking about exercise or movement in general?
Yeah. So this is fascinating, and we have the luxury of having a lot of research on this. So first thing to say is exercise is good, period. Almost any physical activity, even just walking around or even just standing up more, reducing sitting time has been shown to lower blood pressure.
Yeah.
So that's the first thing, because most people in the West are just not exercising enough, not moving enough, even at a first level. And then getting more granular for the perfectionists, what type of activity, what type of exercise. So this has all been looked at and compared. And the most powerful workouts are actually what they call isometric exercises. So it's things where you're contracting muscles in the same position. So things
like a plank,
like a plank, or an isometric leg extension is you extend the leg and you hold it there. And the most powerful that I've seen demonstrated is wall squats. So
they're super fun. I remember I'm getting flashbacks from my high school basketball days where we had to sit there for several minutes at a 90-degree angle.
Yeah, it's probably like
knees shaking.
Right. When you misbehave or something, you go do a wall squat.
Yeah.
But yeah, that has been shown to help lower blood pressure by 10 points, which is in the range of a medication, which is insane. Wow.
Yeah.
And it's something that you can do for free. Doesn't cost anything. You can do it anywhere. You don't need a gym.
But it's miserable, Gil.
it's yeah.
You don't just take a pill. You have to work your ass off.
It's not the most fun. I guess you could play a game on your phone while you're wall squatting.
You gotta find some way to make it fun.
Find a way to.
Exactly. Yeah. That's right. Okay. Well, there are a lot of things we can do. Diet, lifestyle, drugs when necessary. Let's shift into the metabolic health realm, because we've been focusing on cardiovascular health. These are related, right? But let's talk a little bit more about metabolic health. What is metabolic health and why does it matter?
Honestly, I'm not a fan of that terminology. I think it's a bit of a misnomer. I think because metabolism is everything. Metabolism is every chemical reaction in your body.
Yeah.
Cholesterol is part of metabolism. ApoB is part of metabolism. So I think I understand what people mean when they say metabolic health. Usually they're talking about glucose metabolism and sometimes also incorporating blood pressure and inflammation and things like that. But sometimes I think this is a little misused on social media, and people use it as all health except cholesterol and ApoB. It's like, let's focus on anything except these metrics. And I think sometimes it's...
Yeah. Would you say the term cardiometabolic is a more appropriate term to encompass all of those sort of effects?
I think it's health, really, because everything we've been talking about is metabolism. Everything. Blood pressure, LPA, it's all part of metabolism.
Yeah.
In fact, if you Google cholesterol metabolism, it's a thing. It's a chapter in medicine.
Right.
So it's kind of a misnomer. But I understand what people mean. They're talking about mainly glucose metabolism. They're talking about diabetes, insulin resistance.
Exactly. Let's talk about. Thank you for that education. I think you're absolutely right. Let's talk about glucose metabolism, which I'm sure you'll share is also related to all forms of metabolism. But it is important because some people are more susceptible to diabetes risk, right, versus heart disease risk, and there are different pathways for those diseases.
Yeah. And also a major risk factor for heart disease, as we said. So I think these things all overlap and all touch each other. There's individual variability as well. The main driver seems to be, from the data we have, I wouldn't say this is the only one, but it seems to be the big dog, seems to be adiposity, excess adiposity, which typically comes from an excess, chronic energetic excess. So eating too much chronically, which is the norm in the West. And so that tends to lead to adiposity. And specifically, we know there are these different fat depots. There's the subcutaneous fat and there's the visceral fat. And it's the visceral fat essentially that deposits inside or right around the organs, the visceral, like the liver, the pancreas, the spleen. This seems to be the nastiest type of fat that causes these problems, the insulin resistance, the diabetes. So that's mainly what we're interested in targeting. And it varies a lot from person to person. So some people have large subcutaneous storage room and they can store fat in there and they can even be overweight. Some people are obese and you look at their blood work and it's still pretty good.
So it's where the fat is stored on the body,
Right.
whether it's under the skin, right, subcutaneous, or whether it's around the organs, right, that visceral fat.
Yeah. And but then others, and sometimes it depends on ethnicity as well. Asian populations, they can't handle as much body fat. They get into these issues faster. But yeah, it varies from person to person. And this seems to be the main driver of diabetes, insulin resistance, and all these issues.
And you mentioned some of the key markers. Can you just repeat here for clarity? What sort of lab tests should we be looking for to test our glucose metabolism?
Yeah. So similar to what we saw with cholesterol and ApoB, there are more common markers like a fasting glycemia, for example, a hemoglobin A1C. Those are more common, but they're not the most specific. So I would absolutely look at those, but then you may have completely normal fasting glucose, completely normal hemoglobin A1C even, and you can have insulin resistance that over the years can aggravate to prediabetes and even diabetes depending on the person. So there are also measures that are more sensitive that pick up insulin resistance. There's a number of ways to measure it. There's something called HOMA-IR, where you basically measure your fasting glucose and your fasting insulin level. And then there's a very simple formula. There are calculators on social media or on the internet where you enter those two values and it spits out your HOMA-IR value. So that's one way to kind of get a more sensitive measure of your glucose metabolism.
And that's sort of
subclinical.
Okay, subclinical, because you're picking it up earlier in the disease process, right? Where you can act before it's really altered your fasting glucose, your HbA1c, right?
Yep.
Okay. And what about others like triglycerides? Is there anything related to the lipids that we should pay attention to? Yep.
Triglycerides are correlate with insulin resistance as well. Sometimes people use these ratios of triglycerides over HDL because both of those will tend to reflect insulin resistance. They're not the most specific thing in the world, so I would be careful with those. But yes, in general, that ratio can be what's it called? Like a red light.
So maybe because they're commonly done on a standard physical, at least in the US, you get your standard lipid panel includes triglycerides and HDL. So if you're not getting, I think you have to ask your doctor if you want to get fasting glucose, HbA1c, if you want HOMA-IR. But you may just from a standard panel, you may just have your triglycerides, your HDL. That can at least let you know if there's a concern, right?
Yeah.
And again, it's like there are more specific markers, but if you already have those tests, you can say, okay, well, I need further testing to know what's going on here.
Yep. Yeah, I think triglycerides, if your triglycerides are frankly elevated, there's a very high probability that you're insulin resistant, and it's very common in the West. And if you're carrying around, significant weight, extra weight, if you've put on some pounds into your 30s and 40s and 50s, there's a good chance also that there's some insulin resistance. So yeah, this is very common. Some people call it an undiagnosed epidemic. I think not enough attention is given to that. I think it's a concern.
So what about this? I would say it's something that's pretty hyped up, but these continuous glucose monitors, CGMs, they've been very popular in the health community. Can you talk about what they are and what are their pros and cons?
Yeah, so they're little devices that you can implant typically on your shoulder or sometimes in your abdomen. And they basically detect your glucose levels, not in the blood, but in your interstitial fluids, in your interstitial tissues. And they basically give you a real-time measure, let's say a guesstimate of your glucose levels in the blood. There are studies showing that it's not quite, there's a difference between what that measures and your blood levels. There's some discrepancy there, but it's an approximation. And so you can eat different meals, and this typically you have an app on your phone, and it shows your glucose in real time going up and down after a meal. And it's unambiguously very useful, very important tool for someone with diabetes, and I think even for pre-diabetes. For a healthy person, I think they can give you interesting information. I think they can sometimes get overinterpreted, and I think the problem is not the device. I think the problem is sometimes lack of information, and someone looking at a change in glucose after a meal and seeing the glucose go up. And if they don't understand the basics of how glucose metabolism works, that can be scary, because typically we associate elevations in glucose to diabetes.
Right.
And you can even look up, what is diabetes? Oh, it's a glucose over 126. Oh, but I had a piece of bread and my glucose went to 140.
Carbs are killing me. Yeah.
Yeah, the bread is giving me diabetes.
Yeah.
So it's the lack of information that these are two separate worlds. One thing is fasting glucose over 126. A completely different thing is a postprandial, what we call a glucose excursion. Glucose going up and down after a meal is completely normal and physiological. And an example that I like to give is blood pressure goes up during exercise, and that's completely normal and even might be healthy. But if your blood pressure is high all the time at rest, that's a problem, right? So that distinction between acute versus chronic.
Right. Makes a lot of sense. Another topic that gets a lot of attention, or at least the phrase gets thrown around, is low-grade chronic inflammation. And people talk about different diets that cause inflammation, different foods even, right? Can you tell us, make sense of this? What is low-grade chronic inflammation? How does it affect our health?
So there's different causes of inflammation. There are conditions that are inflammatory conditions, autoimmune conditions, some gut conditions, like IBD, that can cause inflammation. And in these individuals, you can measure inflammatory markers, and they'll be elevated chronically. And by the way, that is one risk factor for heart disease. These people have higher risk of heart disease than someone with lower risk of inflammation. So it is a concern. There is also, with weight gain, when you carry too much body fat, typically we see inflammatory markers go up. And with weight loss, reproducibly, we see inflammatory markers come down. So that's another common cause, because the fat tissue itself will secrete inflammatory markers and inflammatory factors. It will secrete adipokines and other molecules that cause inflammation and cause these
regardless of right. So regardless of what you're eating, if you have excess body fat, that can be generating this chronic inflammation itself.
Right. And it's in my experience, looking at different studies, it's a much more dramatic driver of inflammatory markers than any specific food. When people talk about this food is inflammatory, first of all, 9 times out of 10, when people on the internet say this food is inflammatory or this food cuts inflammation, it's complete nonsense. It's hype on the internet, and sometimes it's not even backed up by research. Seed oils would be one flagrant example that people love to say are inflammatory. And then you go over the studies systematically. There's dozens of randomized trials giving people seed oils, and then long-term cohort studies, and you don't see this effect. So this is like a very easy way to get clicks, is that this food is inflammatory because it's scary. But really the main thing is, if you put on weight, it drives up your inflammation. And if you lose weight, it drives it down. On top of that, yes, there are studies that try to look at dietary patterns that are more inflammatory versus less. And you fall on the exact same stuff that we've been talking about all along. You fall on these Mediterranean type dietary patterns with the fruits and vegetables and the unsaturated fats and the olive oil and the fatty fish and the fermented dairy, the same stuff, right? We tend to see better inflammatory markers. And when you get into the ultra-processed junk foods, the sodas and all the refined carbs and the processed red meats, you tend to see more higher levels of inflammatory markers in general. So that's the main thing with that. And then the last point would be individual variation. If you have a specific intolerance, like for example, celiac that we touched on, obviously, if you have celiac disease and you eat something with gluten, there's going to be an inflammatory response, but not for a healthy individual, not for someone without celiac. Like wheat doesn't drive up inflammation in me or someone without celiac.
Yeah.
So different, a slight distinction there.
Mm-hmm. So lastly, we talked about diet and lifestyle for, cardiovascular health. Are there specific things that people should focus on to optimize or improve their glucose metabolism? Now, I'm sure this varies whether you have some sort of risk like prediabetes or if you have diabetes versus if you're generally healthy. But what can people do to try to get their glucose metabolism under control and make sure that they're not going to fall into this sort of prediabetes if they're not there yet?
Yeah. So there's endless wars online. It's people insisting that you have to be low fat because it's fat in the diet that causes diabetes, and others insist you have to be low carb. And there's all these factions. But the truth is, when you look at the evidence systematically, it's excess body fat that is the main driver. I don't think it's 100%, but it's the big dog by far. And when you lose weight consistently, we see this in trials. We see glucose metabolism improving, and even people putting their diabetes in remission, quote unquote, reversing diabetes via weight loss on all kinds of diets. Low carb, low fat, plant-based, animal-based, Mediterranean, they've all been shown. Mm-hmm. And so it's just very hard to make a scientific argument that it's about the fat you eat or about the carbs you eat. Of course, if you eat a lot of refined carbs, it can lead to weight gain because if you drink a lot of soda, if you eat a lot of sugary cereal, it's going to be easier to overconsume energy and easier to put on weight. But that doesn't mean it's carbs in the diet. And the same for fats. I just don't see an argument for macronutrients, period. I think it's possible they play maybe an ancillary role there. There are some studies where they hold people without weight loss, so weight maintenance, and you see some change with some with low carbs, some with low fat. So I'm open to there being an effect there, but it's not the magnitude of effect that we see with weight loss, where you take someone who's frankly diabetic and you bring them to normal fasting glucose, sometimes in a week. I've had on Roy Taylor, one of the leading experts on diabetes, and he sees this within 8 days. He sees the fasting glucose normalize. Amazing. On these weight loss diets. So, it's insane. And this is another thing that in medical school we didn't learn. I learned that diabetes was it. Like you have it, you're done. You have it, now you manage it.
Right.
But it's insane. You can literally reverse it in days or months with the right tweaks to your diet.
Yeah.
Yeah.
It's incredible. So excess body fat is really the primary thing to pay attention to. So getting your weight under control, getting your body fat under control. How about exercise? How does that affect glucose metabolism?
Yeah. Huge. First of all, because it helps a little bit with the weight loss as well. Even at without counting the loss in fat and weight, exercise helps because it increases the glucose uptake by the muscles. And so postprandially, for example, you're going to have an easier time removing glucose from circulation. So your postprandial glucose is not going to be so exaggerated. In the case of people who have some of these conditions like prediabetes or diabetes, exercise is fantastic. Another thing that's widely recommended is after a meal, taking a walk, some light physical activity. You don't want to go for a marathon after a meal, but taking a walk, moving around is going to help as well with that glucose removal from circulation.
Stabilizing your blood sugar.
Yeah. And resistance training is another thing within the chapter of exercise. All exercise is great, but there's a recent kind of rise of the importance of resistance training because your muscle mass is an important recruiter of glucose. And so sometimes you may not be very overweight, but if your body composition is very skewed, like you're skinny fat, right? You're not very obese, but your muscle mass is very low compared to your total body mass. That can create problems at the level of glucose metabolism, precisely because muscle mass is very reduced, and that's a big destination of the glucose.
So muscle is very useful for a lot of things. Obviously, in older age, to be able to stay mobile and avoid, falls and things like that. It's also important because it takes a lot of energy to maintain. So it's helpful for regulating body weight itself. But you're saying there are direct benefits to, glucose metabolism to have, a good amount of muscle mass. So, we talked a lot about the details around things, maybe at a level that was, for some people, may have been into the weeds. But I think we, to tie it all together, what you're saying is including a lot of minimally processed plants. So fruits, vegetables, whole grains, legumes, nuts, seeds, for those who do well on them. That is a really good strategy for longevity for most people. It can be good for your cardiovascular health. It can be good for glucose metabolism, for weight regulation. And, in addition to having a general healthy diet, having, consistent movement and exercise. So doing a bit of strength training, doing a bit of cardio, doing a bit of movement where you're walking maybe regularly, you're trying to stand more instead of sitting. I have a standing desk, so I generally am standing when I'm working instead of sitting down. I think those types of things all play a role in our health. Now, if you could just let the listeners take away one thing from the episode, let's say they zoned out during some of our nitty-gritty discussion, what would you want them to take away from this conversation?
Focus on the big things first. Fix the big things first before you get perfectionist, before you get into the details. I would add another thing that we've touched on maybe, but I would emphasize the personalization aspect, because what we see consistently with a lot of research is, even though all of these dietary patterns that we talked about can work, long term, we see really miserable results with all of them in terms of like low fat, low carb, even Mediterranean interventions. Most people struggle to maintain a dietary change long term. And so I think what's absolutely crucial, and we've learned this over the years, is find something that works for you. If the traditional Mediterranean diet works really well for your neighbor or your cousin, but you just can't stick with it, find something else, like tweak it. If it's a low carb version and you hate oatmeal, don't eat oatmeal, eat something else that's healthy. Right? Find something that you find sustainable and delicious, and you enjoy it and delivers the results. Because there is a lot of variability, a lot of variety. Within this umbrella of health promoting, there's a lot of variety. There's a lot of ways to put together a health promoting diet. You don't have to mimic what the influencer XYZ is doing. Find your way of doing it that's still healthy.
Wise words, Dr. Gil Carvalho. Thank you so much for joining me today. I really enjoyed this discussion.
Thanks, Matt. My pleasure.